metaplasia occurs in the esophagus, this condition is called Barrett's esophagus. When this happens, the normally smooth tiles of the esophagus lining look more like shag carpeting. When the change extends no farther than 3 centimeters, or about an inch up the esophagus, it's called short segment Barrett's esophagus. When it extends farther up, it's called long segment Barrett's esophagus. The cells involved in Barrett's esophagus are not cancerous when they first appear, but over time, they might become abnormal. If you have been diagnosed with Barrett's esophagus, it's wise to have follow-up examinations of your esophagus. It's also wise to take immediate steps to reduce the reflux, which leads to Barrett's esophagus. Mayo Clinic has a very large team with an
This animation will show how a hiatus hernia forms. There are 2 types of hiatus hernia, sliding and rolling. This animation focuses on the more common type, a sliding hiatus hernia. Click the navigation arrows below the animation screen to play, pause, rewind or fast forward the animation. Your esophagus, the pipe that goes from your mouth to your stomach, passes into your stomach through a hole or hiatus in your diaphragm. Normally, the stomach is situated completely below the diaphragm, as shown here. The esophageal sphincter acts like a one-way valve to stop the acid that's produced in your stomach to break down food from flowing up into your esophagus. Here we show the valve opening and closing. In a sliding hiatus hernia, the sphincter and the top part of the stomach push upwards into the chest. A hiatus hernia can prevent the esophageal sphincter from closing properly. If this happens, acid from the stomach can pass into the esophagus and cause discomfort known as heartburn. However, often hiatus hernias don't cause any symptoms. Sliding hiatus hernias are usually quite small. They can slide back and forth through the hiatus, so symptoms can come and go. Sometimes sliding and rolling hiatus hernias are present at the same time. This is known as a mixed hernia. This is the end of the animation. Click on the animation screen to watch it again. To watch it
again. Thank you so much for watching inflammation, bowel syndrome.
Chris, I can't believe you.
I didn't do it. I did that.
Okay.
Camera's on. Half of me cut. Oh, it is hilarious.
We post funny videos. All right, so ulcerative colitis. I want to just try to get through the rest of this chapter, so I'm going to try to go a little fast if you don't mind. The information with this chapter is pretty straightforward. It's not a whole bunch of heavy stuff, okay? So with ulcerative colitis, please keep in mind that these are definitely going to be ulcers that actually form in a mucosal layer from just the layer of the colon and the rectum. Okay, so just the colon and the rectum. This does not extend all the way through the intestines. Please keep in mind with ulcerative colitis that these individuals, it can increase their risk for cancer, okay, for colon cancer. The hallmarks here is bloody diarrhea. I would definitely highlight that. This is actually one of the most common sign and symptom with this particular this type of disease. I did see this as an NCLEX question, just to let you know. Bloody diarrhea is usually associated with ulcerative colitis, along with lower abdominal pain. The other thing with this disease, these patients can have exacerbations and remissions. So sometimes they can have a remission of this situation and feel fine, and then just have a re-exacerbation and not knowing what causes the exacerbation. Okay. Now the treatment here is corticosteroids, salicylic analogs, which actually help with the diarrhea. Corticosteroids actually help with the exacerbations, okay, that they have. And then they do also give them types of medications that can help with the inflammation, so immunologic type agents. I'm sorry.
What does the corticosteroids help with?
Yeah.
Oh, I'm sorry. Corticosteroids help with the acute exacerbations. It helps with the acute exacerbations. That's a picture there. I'm not quite sure if you can see that well, but this is the, no, not the, it looks like a liver.
Like a liver dish.
But this is actually a person's colon, okay, lower part of the colon and rectum, near the rectum. And basically what they're showing you here is that it's so ulcerative that it looks very bloody, okay? And so this is hence the reason why they have bloody diarrhea, okay, that goes along with this. Now, Crohn's disease, okay? Crohn's disease is, believe it or not, quite common, okay? Crohn's disease, what happens with this situation is these patients have an inflammation of all layers of the GI wall, so submucosa, mucosa, muscularis, serosa layers, all of the layers. This is a very chronic illness. But the other thing too is that it's only localized to the portion, proximal portion of the colon and terminal ileum. Please make sure you highlight that. The reason why I want to stress that is because one thing that when you get to the treatment that they're missing here is that sometimes patients with Crohn's disease do have surgery. And because they know that this really affects that portion of the colon, they could just take out that portion. And that my niece actually had that surgery done. She suffered from Crohn's disease for years. They took out the portion of her intestines and she was fine. Okay, never had a problem since. So this is an inflammation of that area. Okay. So this is trying to show you a picture here what happens. So as you can see, it does erode a little bit, showing a little bit of erosions of the mucosal layer there. Now, signs and symptoms here, they can have intermittent bouts of fever, diarrhea, right lower quadrant pain. Please highlight this because this can sometimes be confused with, say, an appendicitis, okay, if you look at the signs and symptoms here, because they will have tenderness also in that area. They don't know exactly what causes Crohn's disease. Sometimes with these patients, keep in mind that the first thing they usually go to is that it's something that they're eating. So usually they'll do like a food diary with them to see if maybe dairy products or certain meat products or whatever it is that may be causing this issue. And by eliminating certain foods, it can suppress some of their symptoms, but there's really no known cause for it, okay? Crohn's disease can be very debilitating, and I believe in your book they even say that patients with this, they even go to support groups, okay? Because you could just be sitting in your seat and then all of a sudden you have diarrhea, okay? So, you know, and not knowing when it's going to come on, okay, or what's actually causing it. So, I'm sorry. So, okay, and the drugs also that they treat similar to ulcerative colitis where it will just kind of calm down that inflammation. Yes. You had a question?
Way up. Nope.
Okay. Enterocolitis. Okay, and I'm quite sure you guys probably went over this in micro, maybe? Did you go over C. diff?
Yeah.
Okay, so C. diff actually gives patients the title or the condition of enterocolitis. Okay, so these are the patients that love taking antibiotics. Okay. And my mom actually got this, and I would tell her for years and years, stop taking antibiotics. You take antibiotics for everything. Oh, they give me a prescription. So she developed C. diff, and what happens with these individuals, the overuse of antibiotics, as you know, this can definitely cause an issue with the GI tract, cause a whole bunch of inflammation. These patients do have diarrhea, abdominal pain, fever. It can get to the point where it causes a lot of irritation to the intestinal wall, to the fact that it can actually cause perforations in the wall, okay, if it gets that severe. Okay. But usually by the time they're vomiting and diarrhea and everything, you know, by that time. So, how do they treat this? Stop taking the antibiotics, okay, that they're currently taking, and treat them with another antibiotic. So that's the treatment, really. And obviously, what else would you give to your patient? Just common knowledge. Probiotics, that's a very good answer. And what else? What would you do in the hospital?
For these patients, they take fecal matter of a closely related relative and put it in that patient for the normal flora for proliferation. That's what I know they do that.
I heard of that. Do they do that? That's a standard protocol?
For C. diff, yeah.
Oh, okay. I didn't know that was a standard protocol.
Yeah.
But I was just looking for IV fluid. But I didn't know that, but that's good to know. I'm just saying. I did hear of that. And I remember Dr. Williams telling me that, but I wasn't sure if that was for every patient. I thought that was only select situations. Okay. Well, that's good to know that that's for everybody. So, just in case. Now,
My mama needs a boo-boo.
necrotizing enterocolitis. This is a type of enterocolitis that can actually happen in babies. Okay. So what happens here is that these infants are born and they do go through a type of necrosis in their intestines. Now what causes this necrosis, again, is not quite known. Okay, there's no known cause for it. But this type of necrosis can lead to them having a septic situation. Okay, so if we have a necrosis, please keep in mind that any organ or tissue that gets necrotized, it will actually is dead at that point. There's nothing you can do for it. So the best treatment is surgery. They're going to have to cut out that portion of the intestines, okay, along with antibiotics to help with possible infection. Okay. Keep in mind too with antibiotics, just to give you a heads up, and you guys probably know this already, most of the time with antibiotics, as you know, they do give it if it is a known bacterial infection, but sometimes you will also just kind of pre-treat and give antibiotics, especially in situations like this where the patient is more susceptible for getting bacterial infections and things of that nature. Appendicitis, we all kind of know this, have heard of this. Keep in mind with appendicitis, the appendix, we all know where it's located. You guys went over that in anatomy. This is when the appendix gets inflamed, or sometimes fecal matter can get stuck there. Okay, so if fecal matter gets stuck in the appendix, obviously this will cause an inflammatory process. And now this patient having signs of that right lower quadrant pain, right at McBurney's point, nausea, vomiting, fever, so all the signs of an itis or sort of like a viral type of thing that they may be experiencing. And keep in mind that the treatment for this is immediate surgery because of this appendix and the location and the size of it, that if fecal matter is there and a high amount of inflammation, the appendix can rupture. Now, if the appendix rupture, just imagine if it is fecal matter and it ruptures, it's sorry to be gross, but now you have all of that spread out through the peritoneum, okay? And now where a person can now start to get peritonitis. And if they get peritonitis, now with all of that fecal matter and whatever else is going on there, now they can get into more of leading into a sepsis, okay? And then if it gets bad, septic shot if it gets that, but it usually doesn't get that bad. Okay, so, and that's usually what happens, okay, with the appendicitis, so just keep that in mind. Okay, now, diverticulum. Okay, diverticulum or diverticulosis. Okay, we do have two different terms here that I do want to go over and just make a point out of this. So when we talk about diverticulum, please understand we're talking about the colon, not the small intestines, but the large intestines, the colon. Okay, so we're done with the small intestines, so the colon here. With the colon can actually start to have these sort of out pouches or perforations. I shouldn't say perforations, but sort of pouching that can occur. And that pouching usually occurs because of the weakening of the GI wall. Okay, so what can cause this? They say low dietary fiber. Dietary fiber can keep the colon, the wall of the colon actually nice and say strong, or keep the muscular layer strong. Signs and symptoms, diverticulosis is usually asymptomatic, and so what that means is, say for example, a person has a diverticulum. They're eating food, food is passing through, but the food will get stuck there, but it's there, there may be just a small amount or what have you, but it's there, but it's not causing them to have any signs or symptoms, okay? So please keep in mind that some people do live with a diverticulum and they can live throughout their life with that and not really need any extra surgery, anything like that. But keep in mind that those individuals, and I'm quite sure you've heard of this, they have to stay away from eating peanuts, nuts, and certain little foods that can get trapped in that area. Okay. Now, diverticulitis, this is where they have a lot of trapping there, and that trapping of food in the diverticulum will now start to cause an itis. It will cause an inflammation of the colon, giving them fever, lower abdominal pain. They can even get diarrhea with it. Please keep in mind, too, that if a person has a large diverticulum or a lot of food that's impacted, these people can also have impacted feces. Okay, so what happens is now you're talking about a blockage in the colon. So when the colon, as you know, by the time we get to the colon, it's time for fecal matter or waste. So it's not going to be able to pass through, okay, just because of the situation. So when it's complicated like that, they will do surgery, but for just the smaller ones, if it's just an itis, they'll just give them antibiotics. And that's a cute little picture here. They're showing you the diverticulum here is sort of a little pouch. That's a diverticulum. Okay. Now, irritable bowel syndrome, IBS. Okay. IBS is another one of these things that is definitely associated with stress, anxiety, depression. Okay. That's what they usually say the cause of this. And again, I believe I talked about this before, is that what happens with those type of psychological issues, it can cause the sympathetic nervous system to get activated, which causes an increase of peristalsis. Okay. So with irritable bowel syndrome, these people do have diarrhea. And they say no nocturnal diarrhea, that's a good thing. Flatulence, they're not sure, they're saying they're unclear what happens with the bowel, but it's really the sympathetic nervous system that actually causes the situation. Okay. Keep in mind, IBS is something that's chronic, so I don't want you to think that, oh, you went and ate some Taco Bell and that's now considered IBS. No, IBS is something that happens over a period of time. People don't know exactly what's causing it. And patients that suffer from this is actually quite, as you can imagine, uncomfortable, okay? Because it is a chronic thing and it happens quite often throughout those 3 months or more that it happens. Okay. So diarrhea or constipation, sometimes both, okay, can alternate. Cramping, mucus in the stool, nausea, bloating. So anti-diarrheal meds, that's the only way you can treat it. Antispasmodic medications to kind of slow down those exacerbations that they're having, and tell them to put fiber in their diet. Intestinal obstruction. Okay, now we do have two different types, mechanical and functional, and we're going to go into two different types of intestinal obstruction. Mechanical is when there is something like a hernia, a tumor, something that's causing the intestines to sort of maybe twist on itself, like a volvulus or intussusception, which we're going to go over in detail. Something that's mechanically causing the intestines to not be able to move, okay, or some obstruction. Functional is if there is some sort of issue with the physiological portion, so peristalsis somehow is decreased, okay, or from maybe drugs, anesthesia, they say surgery, certain things can just kind of slow down peristalsis. As you know, there are drugs, and I forgot exactly what drug it is, but there are drugs that actually slow down peristalsis that is usually given to individuals that have diarrhea. Okay. So, and those things can, what is it called? Lomatin. I don't know much about medication. Okay, now, intestinal obstruction, what will happen because it is obstructing the colon area, and we know what's going on at the colon area, so these individuals can go through dehydration, vomiting, and they will have a lot of pain, constipation. Keep in mind that fecal matter, again, can also be impacted, okay, depending on the location. And the way to treat this, please keep in mind, is surgery. When we talk about now an intestinal obstruction, this means that nothing can pass through. So the only way to do it, you can't really give them a pill for that or anything. It has to be removed. Volvulus. Best way I can explain volvulus. Okay? Say, for example, this can happen if a person has maybe a tumor, okay, or something already obstructing, and then this bowel just twists on itself. Or another good example is, let's use children. We know children sometimes, especially 2-year-olds, okay, they put things in their mouths, okay? And say, for example, if a child was to swallow a piece of toy or whatever, okay? And what is the body going to do? It's going to try to digest it, okay? It doesn't know that it's a Hot Wheels car. It's going to try to digest it and push it down. So what will happen is, imagine if you have this toy, okay, that's in the GI wall. It's going through peristalsis and trying to move it down and push it down. But because of the size of that particular object and the fact that the body obviously doesn't have the enzyme to break down that Hot Wheels car, it's now going to cause the bowel to twist on itself. So it's moving, 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 but because it can't push and this car is stuck there, the bowel will actually start to twist on itself. Okay, so this is what happens. And I know I'm talking with my hands, but so results from an anomaly of rotation. So please understand, with the volvulus, this is a rotation of the intestines. So the rotation where it twisted, twisting of the bowel on itself. Common sites are the cecum and the sigmoid colon. Why do you think the cecum and the sigmoid colon? What is it about the cecum?
Was it narrow there or something?
It's very narrow because it curves. Okay, so if you get something that gets in that little pocket there, if you remember how the cecum is shaped, and you try to move it forward and it's not a digestible item, that's not a good situation. Okay, and so it'll definitely cause that twisting. So when we have a twisting here on the bowel, keep in mind that there are blood vessels, there are vascular supply that's on that area. So this can lead to a necrosis, it can lead to gangrene. Keep in mind that it will definitely impede blood flow in that area. Hence another reason why it should be surgically removed. Okay, because of the fact that it will go through a state of necrosis. So signs and symptoms here, again, dehydration, vomiting. It is a life-threatening situation, and they have to remove this surgically, okay, or they say decompression. So this is a very nice picture, okay, that they have here showing you that volvulus. This is a 180-degree twist of the bowels, okay, so the bowel should never be in that position, obviously. Here they're showing you, let's say maybe the obstruction is in here, okay, say the toy is there and it can't move forward. And so the bowel is actually twisting on itself, and they're showing you here this lighter color, showing you that now this area is necrotic, okay. So obstruction, but also it's lacking blood flow. So this area will get necrotic. So I would imagine surgically they would remove this whole area here, okay, if it gets to that point, if they can't do that. Undo that 180-degree twist.
But it doesn't matter because it's necrosis, they'll die, right?
Right, right.
They just connect the good part to the good part.
Right together.
Okay, so that's volvulus. Intussusception is a little different. This type of bowel obstruction is when you have what is called a telescoping, or what they call an invagination, okay, of the bowel. So here we go with the long tube, and just say if it goes like this, pushes, and it folds in on itself.
Oh.
Okay, so it'll fold in. So it's trying to move and move and move, but because it's not obviously in the proper movement, it will now sort to fold in on itself. Okay, so that's intussusception. They say males more common than females. I don't know why with this situation, but in any event, abdominal pain, definitely surgery has to be done here. So this is what it looks like. Okay, so whatever the obstruction is, okay, that's going on in that area, for some reason, as this person's trying to digest whatever the agent is, and the bowel now just kind of folds in on itself, okay, and when it folds in on itself, obviously that decreases the lumen even more, okay, so this is even more of an issue. So person here will, they're not saying this as much, but I would imagine that a person will get impacted feces if this is not dealt with, okay, right away. Okay. Hirschsprung's disease. but this is, I really don't test you on this so much. But in any event, this is, it's no. Let me just tell you what it is, in case anybody's interested. Okay. It is a congenital disorder, okay, where patients can actually start to sort of have I'm sorry, because I never go over this. I'm sorry. I never really go over this. Oh, okay, I know what it is. I'm sorry. I'm sorry. I was confused with something. Hirschsprung's disease is when these individuals are born with a neurological issue, okay, where the neurological response that doesn't allow this peristalsis to occur, okay, or the gastric motility, so to speak. So what will happen here, these infants are born with this situation, so what will happen, they will start to develop obstructions because of the fact that motility is not occurring. Okay? So they give you there how many live births and so forth, most common in infants and children, males more than females. Diarrhea, hypovolemic shock can occur, and they will treat this surgically. Now, let's get into malabsorption disorders. Malabsorption disorders, just quickly, most of the times this is a situation where patients do, I would say number one, lack the enzyme, okay, to break down that particular product, whatever it is that they're eating. Also, they put here infection and radiation enteritis. What that means is that sometimes the GI wall can have an infection or go through an inflammatory response that doesn't allow these people to absorb that particular food that they're eating, okay? So, but most of the times it's usually an enzyme deficiency or issue. Most of the time, again, for signs and symptoms, like most of everything that we've talked about, diarrhea, okay? And we will go into detail with celiac and tropical sprue. Now, celiac spruce or celiac disease, I'm quite sure you guys have heard of this. And this is where individuals are allergic to or have an intolerance to gluten-containing foods, okay? Now, and they were doing this for a little time, and I think they stopped, but they were advertising, oh, to eat a gluten-free diet, that is better for you. No, 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 that's not the case. Please keep in mind that gluten-free diets are for people that have a gluten allergy or a gluten intolerance. It has nothing to do with the nutritional fact that it's better for you, okay? So just keep that in mind. The issue here with these individuals, you remember from anatomy, and that's why at the beginning of the slide it went over the different types like carbohydrates and proteins and fats and how we break those down. The main issue here is that if you remember how we break down carbohydrates, in the small intestines we do have what are called brush border enzymes. Does that sound familiar to you? Brush border enzymes in these individuals are lacking or reduced. So because they lack these brush border enzymes, it does not allow them to absorb those gluten-containing foods. Okay, so this is the issue here, along with the fact that they reduce surface area. Okay. Now, the reason why they make a big deal about gluten allergies or gluten intolerance is that this can lead these individuals, they say, to having intestinal cancer. Okay, so they say that this puts them at risk for intestinal cancer. So, the way they diagnose this, you can do an intestinal biopsy to see exactly what is going on. Do they have those brush border enzymes? Do they have the proper epithelium that they should be having there? You can also do an antibody testing, okay, to see, or allergy testing to see exactly if the body is pretty much going through this sort of allergic response. Now, the treatment here is a gluten-free diet, as you know. And the other treatment here I would definitely highlight is look at all these supplements. Why do you think they have to supplement with all of those different vitamins? Because they are not being absorbed. Gluten-containing foods are, I don't want to give you a list, but it's a lot of things, okay? So a lot of things that these individuals are definitely lacking from their normal diet that they should have. So therefore, they're also going to be lacking the proper nutrition or the proper vitamin absorption, okay? So hence the reason why you should supplement. They need to supplement with these things. Now, tropical sprue, this is another type of malabsorption disease. And with this malabsorption disease, the issue here is that these individuals in the mucosal layer in their small intestines, for some reason, they cannot absorb B12 and folic acid. Okay, and we know that B12 and folic acid is very important. Okay, and so that's not a good situation. So they say adults are more common than children. They do say that this is a type of disease that is common to more tropical areas. And I'll show you why I think this is caused by a parasite, but I think this is kind of a parasitic situation that's going on here. Signs and symptoms here is severe diarrhea, blood-tinged stool, abdominal distension, and steatorrhea. Steatorrhea is fatty stool. Now, I don't know if you went over this in micro, but sometimes when people have parasitic infections, and when parasitic infections actually attack the GI wall, it'll actually start to break down fat in the body. So when it breaks down fat, people have an increase of fat that actually comes out through their stool. So I don't know if you've heard of that, but they do have fatty stool, and usually one of the main reason why people have fatty stool is when they're going through a parasitic infection. So, and that can be from whatever type of parasite. Okay. And that's why I think it's a parasitic infection, even though they say there's no cause for it. So treatment here, they say depends, but antidiarrheal meds and antimicrobial therapy. Prolong, okay, which we know it is some sort of microbial agent. Now, dumping syndrome. Okay, some of you may have heard of dumping syndrome. Yes. Where do you commonly hear of dumping syndrome? And not when you go take a dump.
Well, then you got me again.
I don't know about after exercising, but dumping syndrome is very common when people do have gastric bypass surgeries, lap band, I don't know, all those surgeries, okay, as far as gastric reduction. I'll just put that, gastric reduction surgeries. And I'll explain why. Just keep in mind that after gastric types of surgeries, the body is actually, the stomach is being altered, whether it's shortening the amount of food that's entering the stomach, or you're shortening the size of the stomach itself. So when you do something like that, the number one thing that you would think is going to happen physiological-wise is that it's going to alter how the metabolism process and how peristalsis is going to occur. So what will happen here is that also these patients will have issues absorbing certain foods, okay, because of the size of the stomach now, from a large sausage to a small, whatever it is, okay, that they shrink it to. So, we'll go over all this. I'm going to show you a diagram. It's much easier. Yeah. So, what happens here, and this is actually, I always have a story, but my dad actually went through this. He had the gastric bypass surgery, shortened it. And he had it in June, I think June. My parents came here to visit in August. So, of course, when you